welcome to Understanding Depression, Hope Through Treatment, a 5-part series. My name is Mary Hanson. I'm a social work consultant and the co-host of this series. I've hosted a talk show for 30 years that focuses on health and social issues. My co-host today is Dr. James Jordan. Dr. Jordan is a psychiatrist. He is the former medical director of the Ham Psychiatric Clinic in St. Paul, Minnesota, and the former president of the Minnesota Psychiatric Society. He currently is the psychiatric representative to the Minnesota State Council on Mental Health.
In this 5-program series, we're going to talk about major depression. We're going to talk about the symptoms of major depression. We're going to talk about the diagnosis of major depression, and then treatment and treatment resources for this very, very serious and common condition.
In the upcoming programs, we're going to introduce you to 4 individuals who have dealt with major serious depression, and then talk about depression in more detail. But today we're going to cover the basics. And I want to start, Jim, with just asking you to define what major depression is.
Mary, major depression is a significant and disruption in someone's life. They really cannot function in terms of thinking, or their day-to-day functions have all kinds of disruptions. Their sleep, their appetite, their ability to concentrate. They may lose interest in pleasurable things that they ordinarily enjoy. They may not be able to give attention to the things that need their attention, like their children. They may even have suicidal feelings or thoughts. And these are the markers of major depression. And
the important symptom really of those that you just listed that really differentiates major depression, as I understand it, is the thoughts of suicide. Am I correct?
That's exactly right. Mm-hmm. I mean, when that occurs and it enters into someone's mind, into their day-to-day life, it is such an alien thought to most of us. Mm-hmm. This really tells you that something is happening that really needs your attention.
I have a lot of friends who share with me that they're depressed. Would you define kind of the continuum? There are many forms of depression. Not all depression is major depression. Just briefly, Jim, can you explain the other common forms?
There is a chronic or continuous moderate or low-grade depression. The technical term is dysthymia. Mm-hmm. And this goes on for months, if not a year, in order to make that diagnosis of someone that doesn't have those major disruptive symptoms, but really is not performing at the level that they could or should. They may not have as much interest. They may not be feeling well. They may have physical complaints.
Kind of the blahs?
The blahs. They may go to their doctor and have vague symptoms, nothing really to hang your hat on. That's the kind of, I guess, common mild, moderate depression we call dysthymia. Major depression, though, is a significant change. I mean, this is someone that is going to look very, very different to other members of the family and the community. They're going to really not be able to perform at work. Mm-hmm. They may not be able to get their job done. They may not want to get out of bed in the morning. They lose weight, or they may gain weight.
So much different. What about, Jim, the situational, as I call it, depression, where someone maybe has had a major loss, a death in the family, maybe lost a job, even has had to move from one community to another. Is that another common kind of depression in the continuum?
Yes, it is. A loss and normal grief that we would expect someone to experience and to manifest when they lose a loved one or they have job loss, very common condition here today in our day-to-day life.
So that's sort of appropriate response,
absolutely.
Isn't it, to
absolutely.
What's happened to you?
That's right. And that degree of sadness and grieving might cry and feel appropriately the emotional reaction to those losses. But it won't last for weeks and weeks and weeks. That's when you start to see the clinical manifestations of this. So we have to understand that in all of our lives, things will happen. We look for a normal emotional reaction, and most people are able to understand that and support. We support each other. But those kinds of things can also trigger a major depressive episode. So you can have someone that's grieving, and then they may go into a major depression.
So you're more vulnerable at those times, aren't
That's
you?
right.
Is depression more common now, and specifically major depression, than it used to be? We seem to hear more about it. Has it become a bigger medical problem because of the stresses and strains of contemporary life, or are we just talking more about it?
Well, we certainly have our stresses and strains. I mean, we clearly do in our contemporary life. But also, I think we're getting better at understanding where and when and how this develops in the lives of, for example, primary care doctors now are more and more attuned to looking and diagnosing this in their patients. Patients that come with various kinds of symptoms that you really can't hang your hat on exactly what the problem is. Then you need to look a little further. And right here in Minnesota, we have a statewide program that is screening for depression called the Diamond Project. But this allows primary care doctors to have open perspective on this so that they're not necessarily going for a physical cause when very, very common presence of dysthymia or an onset of a major depressive episode in one of their patients that's coming into the practice, and they get a chance then to evaluate that and see that it stands right next to any other medical condition that needs careful evaluation, careful assessment, and treatment.
I want to take just a quick break. We're going to be back in just a minute talking about the symptoms that Jim has alluded to, and we'll go into more detail and hear more about what they really look like. Jim, you alluded to the symptoms and talked about them some. What are the main symptoms of major depression?
Two categories, Mary, two to think through carefully. On the physical side, you're going to see a disruption in someone's day-to-day functions, their sleep, their appetite. They may lose weight, they could gain weight. They may not be able to sleep all the way through the night, so you have early morning awakening.
Or
Classic.
they may want to sleep all the time too,
and
right?
sleep all the time. Can't get out of bed in the morning. Have a foreboding feeling about the day. Feelings of guilt and obsessing, ruminating about things. Can't get their mind off something, brooding about it, this type of thing. Physical complaints, vague aches, headaches, backaches, kinds of things that don't really amount to something very, very specific, but this takes people to their physicians, not feeling well, and general discomfort. These are the kinds of early findings, and very, very important to pay attention to these changes in oneself or others. Notice in your family, at the workplace, someone that is having these kinds of complaints, because we really like to catch this early, try to make an evaluation, diagnostic assessment, and help someone before it becomes clear that they have other deeper symptoms, moderate, severe ones, of the pervasive sense of guilt, not wanting to live. They may lose significant amount of weight.
You can lose interest in things you love to do, I understand too.
Yes.
Your sexual relationship may suffer.
Absolutely.
Your enjoyment of your extracurricular activities may just go out the window, correct?
Yeah.
So
The
it's-
pleasure that you take in the things that ordinarily give you that kind of satisfaction all of a sudden drift away. And when you think about this and you see parents, you know, the interest that they might have in their enjoying their children, if you see a depressed parent in the early phase or as it advances, you can imagine what a serious thing this can be for a child whose parent really cannot enjoy them, cannot participate in the life of the child. So this is why we want to pay very close attention to this in families and parents to make early diagnosis, because it really does help the children in the family to take care of the mother and the father, the parenting complex for the child.
Well, it can botch up, as we say loosely, your personal life, your work life. Let's say someone listening is feeling like, wow, I've got many of those symptoms or some of those symptoms. I think one of the tough things to do as a person experiencing symptoms is to know where to go. I mean, we don't all know someone like you that we can ring up. What do you advise in terms of getting a diagnosis and really determining, you know, really professionally if you do in fact have depression?
Well, I think one of the places to go, and there are physicians, family practice physicians, for the most part, although there are areas that have shortages, certainly. But let's say in the urban area here, to contact your family doctor and be able to talk about the possibility that you'd like to be assessed for this. In other words, it shouldn't be something that you try to think about in some other way. It's reasonable to go in and say, look, I think I might have some symptoms of depression. Can I talk about this? Can I be assessed? And there are staff, support staff, the doctor himself or herself can do an evaluation. It doesn't really require an extensive amount of time to do a screening and assessment. And that's really what we're doing here in Minnesota, trying to look at this in terms of primary care now. There is a lot of depression that's out there in the doctor's offices where this is one place to go. The other is to go to resources at the workplace, human resources. You know, these are trained people that can help you find help, find consultation, get a formal evaluation. Mental health professionals, psychiatrists, social workers, psychologists, all of these professionals are there to help you evaluate this. And evaluation does not mean diagnosis and treatment necessarily. You can be assessed or screened. And this is the kind of thing you do for your general health. We're trying to imagine doing this for your mental health. It's very much a part of everyday life.
I read somewhere that we don't let a terrible sore throat go more than a couple of weeks. We don't let a broken arm go more than a couple of weeks, but we often do let an emotional problem go on with that maybe possibly Midwest stoicism. Oh, I can tough this out, I can get better by myself. Wrong though, right?
Exactly, and you know, the purpose of our work on this series is about understanding. When you mention a broken bone, you know, or something that comes up in terms of a physical symptom, it usually is very clear for people to take some steps, beginning steps, to find out, get that evaluated. If you break an arm, most people will take a look at this, stabilize that, and then try to get to a place where there's a doctor or an x-ray machine to determine, do we in fact have a break here? Why can't we imagine taking into consideration our emotional life, how we're feeling day to day physically, and then also getting a deeper and better understanding of when sadness or grief starts to move into an area of depression, major depression, or we have a chronic condition, dysthymia. So these are the kinds of possibilities that we can imagine accessing now to some degree, and we want to do more. This is a public mental health issue. In my 25 years in community mental health, this was the kind of thing that we were just hoping to have more and more early assessment, early intervention.
So don't wait. I know you are, a great proponent of doing what you call a thorough evaluation, not a quick and easy 10-part questionnaire, right?
Mm-hmm. Exactly.
Can you get that at your family physician's office? I mean, how does that best work?
To some extent, it depends on the practice, frankly.
Mm-hmm.
Some practices are equipped because they have staff, trained staff there to do an assessment. And these can be nurse practitioners, the physician himself or herself, or they know and have connections with psychologists and social workers, mental health professionals who can do that evaluation. And then once that's done, they can incorporate that back into the medical record and then plan to address that problem along with what other health problems that might exist. In seniors, for example, this is an extremely important thing to do. I would think in all seniors. If you think about just having physical illness, the probability of having some associated stress associated with that, heart disease, chronic illness, treating a depression can actually help with the treatment of the physical illness.
I know too there's a overlap between some of the symptoms of dementia and depression. Well, we're going to take another quick break. We'll be back to talk more about treatment of major depression. Stay with us. I have a lot of questions in this next segment that I want to ask Dr. Jordan about treatment. You're known as a psychiatrist, I think, as feeling quite cautious about using medications, Dr. Jordan, and I know that there's been some very controversial information in the press lately about antidepressants. What's your take on the status of antidepressants right now in terms of treatment for major depression?
Well, if I generalize about this, antidepressants are part of the tools that we need to take care of someone, particularly if they have a severe depressive illness, major depression of severity. There's the likelihood of being able to help them without using medication is very, very small. Having said that, if there is mild to moderate depression, it looks like from the research that's being done, and this is, the final word isn't in on this as yet. We're hoping to get more clarity about it. But there's always, in giving any medication, there's risk and benefit. And so when you're treating a condition like major depression, and my colleagues, all of us think very, very carefully about choosing when to give medication and then trying to find the right medication. The problem with antidepressants is they have side effects.
What are some of the worst side effects, or let's say the most common side effects, Dr. Jordan?
The common side effects, they can cause a person to feel irritable for a while. And a lot of these things, I might just say by introduction, they can occur during the first weeks as someone's acclimating to the dose. But we're not always sure if some of the side effects are dose-related or they are just in that first phase of acclimating.
Or the depression is getting worse.
That's
because
right.
Irritability
That's right.
can be a symptom too, right?
And that's why patients need to be assessed very, very carefully. If an antidepressant is prescribed, they need to be watched very carefully during those first 4 to 6 weeks. That's a trial period. Unfortunately, because of the state of the art and some of the challenges in prescribing medications, many patients have to have several trials before they get the right drug and the right dose. Serotonin reuptake inhibitors are the most commonly prescribed antidepressant
and
today.
some of those meds would be what, Jim?
Prozac would be one of the
One of the big
original
ones.
ones, Paxil, Zoloft, Celexa. These are members of that class, serotonin reuptake inhibitors.
Some people share that they are on several antidepressive meds, and that seems like that could cause a lot of problems.
It can. Frankly, it just can do that. Optimally, I would say not ideally, just optimally, we like to find one medication for someone that has a major depression that is going to help them. And then watch it carefully, as I said, over those beginning weeks, and start to look for those key indicators of improvement. The sleep is improving, the person's attention, focus, their ability to concentrate. Some of those suicidal, fleeting feelings, these are alien feelings to many people. How they think of taking my life, or life isn't worth living. Some of those things are starting to abate. Start to enjoy life a little bit more, enjoying things that ordinarily would be a pleasure. These are kinds of signs that the medication is working, but you need to be monitored, and then getting on a dose so that it needs to be adjusted.
You know, what seems so hard to me is that when you're depressed, your energy is low quite often, your patience isn't great, and yet you have to go through this big process of finding the right med, the right dosage, and it can take weeks, can't it?
That's exactly right.
How do you help people get through that process as a doctor?
Yeah, the way I was trained is that the first part of therapy, being therapeutic and helping someone as a psychiatrist, but other mental health professionals, psychologists, is that you support someone. You know that they're in great pain physically, that they're not well at all. They have a lot of difficulties in terms of functioning day to day, so you support them. You develop a very good, trusting alliance. They need that during these ensuing weeks as they're starting to improve.
You are a psychiatrist, I know, that really believes in talk therapy. What are the main benefits, do you think, of a therapeutic relationship while you're maybe also taking meds, maybe not, but why do you feel so wonderfully strong about therapy, Jim?
Well, I really think that it has to do with what we're working with. We're working with a human being. We're working with someone that has a mind, a brain. And a mind is an understanding machine. That's what it's built for. All of us, young people, older people, they have the capacity for understanding. Now, if they develop this health problem, major depression, we can work with that mind, that brain, and help them develop ideas of what changes they might make in their life, maybe changes in their friends or their work, situations that are stressful. They can develop ideas, alternatives to help themselves, and then that can be part of improving. Even looking back over their shoulder at their past, sort of patterns of the way they think about things. It can really change some of those ideas, and cognitive behavioral therapy is one of the treatments now that has evidence to support that it really helps people during these early phases of treatment.
I'm not sure if it was you or someone else recently said going through therapy and dealing with depression really is an opportunity to learn more about yourself and to make some real positive strides. There are some other things a person can do, and we're almost out of time, so I want to ask you to just quickly list some other things people can do to take better care of themselves, in addition to ideally having a good therapist or being in therapy and using meds if appropriate. What are some of the biggies that we can do?
One of the things that I think is definitely important, particularly with medication, but just using medication and feeling better, is to get exercise. To really start at a certain pace, but incorporate that into your life. You can change your sleep habits and also watch other things that can be contributing to a depression. If you're drinking, using drugs, street drugs and so forth. These are kinds of things that can coexist and aggravate or even cause a depression.
Do you advise that we talk to our family members about it and really say, I need some help in this process?
That's definitely the case. We really have to work at destigmatizing this so we have an open conversation, people know where we're at, particularly if there's risk involved here. Someone's having suicidal thoughts and so forth. Family needs to suspect this, ask about it, be open about it. Psychiatrists will always ask someone about how they're feeling in that regard, because that can be an index of how bad they're feeling, or as they're feeling better, those thoughts go away. They start to enjoy life again.
Leaning on friends and family, I think, is a wonderful option that most of us have, and we should utilize, I think, is what you're saying. Thank you, Dr. Jordan. We will pick up on some of these things and allow you to elaborate on them more in the coming shows. In the next 4 shows, we're going to introduce you to 4 individuals who are dealing and have dealt with major depression. Dr. Jordan will talk with each of them, and I think you'll find it very, very interesting. We will be back next week. If you or someone you know is dealing with depression and needs help right now, call 911. If you want to know where to go in your area for an assessment and/or for treatment, you may call 211. This number can connect you to mental health resources throughout the United States.